Hello, I'm Jeff Curtis, and I wanted to share something quite practical that was presented at the American College of Rheumatology's virtual convergence meeting. It's plenary abstract 939. It's the results from the SEAMRA Trial. So this is a trial that tested the very practical question for somebody with rheumatoid arthritis who's been doing great, like at remission or very close to it for a long time, 6 months, a year, or perhaps years, who's on etanercept and methotrexate, and perhaps a little bit of glucocorticoids, prednisone up to 5 milligrams a day. Do those people have to stay on all those therapies for the rest of their lives? As we know, there's a whole lot of people who frankly just don't want to be on methotrexate, and they might grudgingly agree to stay on it for the most part, but they don't really want to be on it. And yet, if they have to remain on it for what might be years stretching into decades to maintain remission, they might be willing to do it, but they're not going to be very happy about it. And of course, if you have to keep giving yourself injections indefinitely with some of the safety concerns and the insurance and hassle factor associated with doing that, then so be it. But if you didn't have to do that, certainly there's a lot of our patients that might like to get off. So the purpose of this trial was to compare whether stopping methotrexate, leaving you only on etanercept monotherapy, or stopping etanercept and leaving you only on methotrexate monotherapy might be superior. And there's a comparison. Just leave people on both and let them stay that way. You might think to yourself, wait, haven't I seen this trial before once or twice? Actually, you haven't. And the way in which it's different, these people had to be in remission, not DAS28 remission, but real remission. SDI less or equal to 3.3. And even if you don't measure the SDI, you basically have to have 0 or at most 1 tender and swollen joints, pretty normal CRP, and a global score of 1. Like, this is real remission. This is not DAS remission. So these people had to be, in the investigator's opinion, doing great for at least 6 months. And then they had a 24-week lead-in period with 3 visits where they pretty much had to be in SDI remission. You were allowed to bounce around just a little bit. You could have an SDI up to 11. That's up to low disease activity, but not higher than that and still qualify. So if you made it through that 3-visit, 24-week lead-in period and you more or less stayed in remission, then you could be randomized. And the randomization was 2 to 2 to 1 to etanercept monotherapy, methotrexate monotherapy, or just stay on the both as a comparison group. The main results of the study showed that etanercept was superior by itself to methotrexate by itself with respect to the maintenance of remission. So in other words, if you're going to peel something back, take away the methotrexate rather than taking away the etanercept. Now, overall, roughly 50% of the etanercept monotherapy patients stayed in remission. It was only about 29% of the methotrexate monotherapy patients. That was a very statistically significant result. That delta is approaching double. Interestingly enough, though, in the combo therapy arm, the proportion who remained in remission at week 48 was roughly the same as etanercept monotherapy. It was 53%. That was also significantly different than methotrexate monotherapy. So the 2 etanercept arms were more or less comparable. So what that teaches us is that if you're going to peel something off, probably better to peel off the methotrexate, but that even if you leave them exactly as is and you change nothing, but you just put them in a blinded randomized study, there are people that are going to bounce in and out of remission and, may have some near misses. The second important feature of the trial is that if they needed rescue therapy, and they needed rescue therapy if they still had persistent disease activity or flare beyond 2 weeks and tried some short dose glucocorticoids and some pain meds, the likelihood that you could recapture them either back to remission was about 75%, or to low disease activity was almost 100%. So as a practical matter, what it means is that if you're going to try to take one of those 2 meds away, metho or etanercept, if that doesn't work out, the chances that you're going to get them back where they started in remission or close to it are exceedingly high and approaching 100%. So this is nearly a risk-free thing to explore with patients and see how it goes. For those that did flare or had disease worsening, By and large, that occurred into about a 6 or so month time frame. Some people a little bit early as 3 months say, but it's really 3 to 6 months. That's the sweet spot where the people that were going to do badly did badly in that time frame, by and large. So I think as a practical matter to communicate to patients, for those that might say, sure, I'm interested in stopping one or the other, most of my patients at least have a preference about which they'd rather to stop. The trial showed that you're probably going to do better if you stop the methotrexate, continue the etanercept, but there's not that much downside if you have to put the one that you quit taking back again. You're going to recover the vast majority of those people, and they're going to be able to do well again. So I think as a very practically designed study with regard to who's in it, these actually are really the people that I personally would be taking off therapy, or at least having that discussion. I think this provides some useful guidance with some real outcome data that stopping one or the other is reasonable, gives the nod to stopping the methotrexate rather than etanercept, but then makes it in a fairly risk-free way to do so, to just put it back if you have to. What's not yet known is what are the predictors of people continuing to do well. There's a lot of ongoing work to try to sort that out at a patient or a patient phenotype level, but at least on average, I think this is very encouraging that for those that are interested in stopping or tapering therapy to off, that the chances of success are pretty high.